Thanks, everyone. It's now 10 minutes after the hour, and we'll reconvene the meeting to begin oral public comment. I'd like to welcome and thank our public comment speakers for addressing the committee today. All the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period, and in order to make it through all the listed speakers, it's extremely important that each speaker limits his, her, or their remarks to 3 minutes. We will be displaying a timer on the screen so you know how much time you have left. As a reminder, our committee appreciates diverse viewpoints that are respectful in nature and focused on the issues being discussed today. Thank you again to our speakers, and we look forward to your comments. Our first public comment speaker today is Melina Berhan.
Thank you, Dr. Lee. My name is Milena Berhane, and today I'm representing the National Consumers League. Since NCL's founding in 1899 by social reformer Florence Kelley, we have advocated for the critical role immunizations play in the preservation and improvement of public health. We extend our gratitude to this committee for the opportunity to present public comment. An estimated 890,000 Americans have died from COVID-19 during this pandemic that has persisted in the U.S. for the past 2 years. The COVID-19 virus continues to threaten the health and safety of many, especially vulnerable populations such as the elderly and immunocompromised groups. The currently available COVID-19 vaccines have worked to save lives and avoid preventable illness, hospitalizations, and deaths in our communities. The National Consumers League commends the FDA and the CDC on the approval of the Moderna COVID-19 vaccine, which will continue to be a key tool in the public health response to this pandemic. This vaccine has been and will continue to be a safe and effective measure to protecting Americans 18 years of age and older. America's families are hopeful that the Pfizer COVID-19 vaccine will be granted emergency use approval for children under 5 years of age. Hospitalization of children under 5 years of age has soared, further evidence of the need for expanding vaccine access to children in this age group. Vaccinating children under the age of 5 will protect them from illness, but also protect their families, caretakers, and teachers from contracting COVID-19 as well. We are also concerned about the widespread drop in routine childhood immunization rates during the pandemic. According to CDC data released last May, over 11.7 million children have missed doses of their recommended vaccines. We are particularly worried that our nation's most vulnerable children, those who qualified for the Vaccines for Children program, are getting caught up at a much slower rate than children with commercial insurance. The National Consumers League recognizes the extreme importance of immunizations in protecting the health and safety of all Americans and will continue its efforts to increase vaccine confidence and uptake across lifespans. We look forward to the upcoming recommendations by this committee regarding these COVID-19 vaccines. Thank you.
Thank you for your comments. Next, we have Laura Burns.
Good morning. My name is Laura Burns, and I represent TRAPAG, the Transplant and Immunocompromised Patient Advocacy Group. There are about 2,000 of us linked by a Facebook group. About half of us are participants in the Johns Hopkins vaccine efficacy studies for transplant patients and the immunocompromised. TRAPAG strongly supports approval of the BLA for the Moderna vaccine, but we wish that the approval could take the straitjacket off our doctors and give them the ability to individualize our care. I'd like to quote something Dr. Dori Segev, the head of the Johns Hopkins studies, said in an interview a couple of weeks ago. Quote, "So, for example, if one of my patients got 3 doses and they ended up with a relatively low but still positive antibody, I would want to give them a 4th dose to boost them up so it will be much higher. But I can't do that today. The only 4th dose that people can get is if they had 3 doses 6 months ago. Now they can get a 4th dose as a booster, but not to complete the primary series," unquote. Our group is very active on Facebook, and we are all discussing our individual dilemmas. For example, a number of people get infusions twice a year. Many find their 5-month booster falls at the same time as their infusion. But they know from their doctors that the infusion will negate the vaccine effectiveness. What to do? We're seeing the same thing with Evusheld. People know they should get boosted before Evusheld. And wouldn't it be better to get the booster now 4 months after their third dose and then Evusheld, rather than waiting a month for the booster and then another 2 weeks for Evusheld. 6 weeks. Likewise, many of our doctors tell us they wish we could get a full dose of Moderna for our booster. They think it makes more sense for the immunocompromised, especially if we had a weak response to the primary series. I'll close with another quote from Dr. Segev's interview. As doctors, I'm sure you'll be able to appreciate it. Quote, look, this really needs to be individualized. We can't keep going. The CDC, FDA guidelines can't be this really complex decision tree of, well, did you have 3 doses and was your antibody level less than 250? And if it was, are you taking MMF? And if you are, then you should get a 4th dose, but it should be at 2 months, whereas this other person should get it at 4. I mean, that's just way too complicated for a big government agency to be doing. But that is what doctors do. That's like what medical providers do. They individualize care for their patient. The difference is for any other medication I give my patient, I have the permission to do so. For vaccines, we don't have permission to do so, unquote. Committee members, thank you so much for your attention and for all that you're doing to keep us safe. Again, we fully support the BLA for Moderna. Thank you.
Next, we have Dr. Leila Sani.
Good morning. My name is Leila Sani. On behalf of Texas Children's Hospital, I would like to thank the CDC employees and ACIP members who have diligently analyzed COVID-19 epidemiology and vaccine safety and efficacy data and adeptly provided risk-benefit assessments based on this information. Using your in-depth analyses, my colleagues and I have been able to assure families of the safety and effectiveness of COVID-19 vaccines. As an epidemiologist with more than a decade of experience conducting pediatric infectious disease research, I know that vaccines are the best way to protect people from COVID-19 and are our best hope for ending the pandemic. As you continue your discussions today and in the future, I urge you not to minimize the risk of COVID-19 to our youngest children under 5 years of age. To date, almost 10 million children have been diagnosed with COVID-19, with almost 2 million cases and almost 400 deaths occurring in children younger than 5. Early in the pandemic, compared to the elderly, children were thought to be relatively unaffected by COVID-19, and pediatric hospitalizations and deaths have been largely overshadowed, causing many to question the need for COVID-19 vaccines for children. However, with the arrival of the Omicron variant, children's hospitals across the nation have reported dramatic increases in COVID-19 hospitalizations. As we continue to vaccinate persons 5 years of age and older, we drive COVID-19 into the unprotected group of our youngest children. As a result, hospitalization rates in children younger than 5 years are the highest they've been at any point in the pandemic, peaking in January almost 5 times higher than they were last year. Children younger than 5 are typically unable to wear masks for extended periods of time and don't understand the concept of social distancing. At the same time, we know that interaction with other children and early childhood education are essential for child development. Parents of young children have no good choices. They must either accept the risk of infection as a consequence of social interactions and preschool attendance in communities with high levels of COVID-19 and minimal mitigation measures, or they must forego the important benefits these activities confer. They deserve better options. Although the immunogenicity of a 2-dose primary series of COVID-19 vaccines for children under the age of 5 produced a less robust immune response than desired, there is every reason to believe that it provides some protection. The safety profile of this vaccine is reassuring, and the 3rd dose currently being studied is expected to provide comparable protection to COVID-19 vaccines given to older children and adults. For these reasons, ACIP must act expeditiously to recommend COVID-19 vaccines for children younger than 5 years of age as soon as emergency use authorization is granted. As we approach the 2-year mark of the COVID-19 pandemic, we must do everything we can to minimize further detrimental effects to young children, many of whom cannot remember a life before the pandemic. COVID-19 vaccines are safe and effective for children of all ages, and I urge you to give these factors your every consideration. Thank you for your time.
Thank you for your comment. Next is Mr. Kermit Kubitz.
Good morning. My name is Kermit Kubitz, and I support the comments before me of the National Consumers League and the Transplant Group. The success and positive benefit risk of COVID-19 vaccines is clear. And the most important slide that I saw in the presentations this morning was the success in vaccination of preventing more than 10 million hospitalizations and more than 1.1 million deaths. That is, without the COVID-19 vaccines, we could have had 2 million deaths from COVID-19 in the United States instead of the 890,000 so far. And further vaccination will allow a return to normalcy. So I support the COVID-19 vaccine BLA for Moderna. Increased vaccination will allow a return to normalcy. Denmark, for example, has recently lifted COVID restrictions because of its high vaccination rate of more than 80% compared to the U.S. of about 64% fully vaccinated. And if we want a return to normalcy, if we want a return to schools without masks, if we want a return to dining in restaurants, if we want a return to meeting in groups, we must have vaccination to the level that reduces the pandemic to an endemic, if that is the future. I also support rapid development and approval of lower cost vaccines like biological ease Corbevax, which is capable of promoting more widespread worldwide vaccination. The development of variants around the world threatens all of us. No one is protected until everyone in the world is protected, and we must support global vaccine equity and increase vaccination of the 70% of the world which has not received the same vaccination levels in the United States. And I want to thank all the doctors and nurses around the country struggling with the pandemic and the result of the pandemic of the unvaccinated causing hospitals to be overwhelmed. Thank you, CDC and FDA and ACIP members, for all you do.
Thank you for your comment. Next, we have Dr. Aaron Prosser.
I want to thank the committee for the opportunity to provide comments. My name is Dr. Aaron Prosser, medical resident at McMaster University in Canada. COVID-19 vaccines have been a vital tool for reducing the burden of this disease on healthcare systems. My comments pertain to COVID-19 vaccine mandates. This is because policies set by the CDC influence whether COVID-19 vaccination will, for example, be a condition of employment or education. In addition to increasing vaccination levels, mandates isolate those who remain unvaccinated from accessing various settings. The hope is isolation will reduce transmission from the unvaccinated. This is based on the idea that unvaccinated people are at high absolute risk of transmission in non-household settings. These risks are thought to be high enough to justify excluding the unvaccinated. However, these absolute risks have not been quantified. The arithmetic is simple and the data is publicly available. These absolute risks are the combined probabilities that an unvaccinated person gets infected and transmits COVID-19 in a given type of setting. My colleagues and I have quantified these absolute risks in a recent paper which, while a preprint, is timely. Dividing one by these absolute risks gives a metric similar to the number needed to treat, which we call the number needed to isolate. In the United States, once a wave of infection subsides, we found that on any given day, the absolute risk of a transmission event in healthcare or educational settings is between 1 in 1,000 and 1 in 3,000. In other words, on any given day, we would have to exclude between 1,000 and 3,000 unvaccinated people from working in healthcare or accessing education to prevent one transmission event. Please note, this is to prevent usually mild, sometimes asymptomatic infection, especially given the high levels of immunity already present in the population, particularly the most vulnerable. And so my comment is one of proportionality and compassion. COVID-19 has been devastating. COVID-19 vaccines are beneficial, especially for preventing severe illness, but our policy responses towards unvaccinated people needs to be proportionate to the risks, compassionate to the harms of these policies, and open to accommodation. In medicine, there is a clinical intuition that if one has to apply an intervention to hundreds or thousands of people to extract one benefit, a careful weighing of harms and benefits is needed. We may disagree with the viewpoints of people who remain unvaccinated, but we must consider the harms of exclusion through mandates, which includes making people unemployed, unemployable, and unable to access education. My one request is that you clarify your position on COVID-19 vaccine mandates, since your decision today on this question will echo throughout the United States and beyond. I think it is important that this be part of the public record. Thank you very much for your time.
Thank you for your comments. Next, we'll move on to Mr.
Hello. My name is Steve Kirsch. I'm the Executive Director of the Vaccine Safety Research Foundation. I have no conflicts. My remarks, as well as all the supporting data, are posted on my Substack at stevekirsch.substack.com. There are 4 compelling reasons why you should not approve the Moderna vaccine. Reason number 1, after 90 days, the Moderna vaccine has negative efficacy against Omicron. You cannot possibly approve a vaccine which, after just 90 days, shows negative efficacy against the predominant variant. This was very clearly shown for the Moderna vaccine in the Denmark study and subsequently confirmed by data from the German government. There are now over 13 studies, including the famous Harvard study, that clearly shows that the infection rate is highest in those countries with the greatest vaccination rate. If the vaccines worked as claimed, how do you explain these studies? Reason number 2, the Moderna vaccine kills more people than it's likely to save. A conservative estimate of the number of deaths using the VAERS data and CDC's own methodology shows the Moderna vaccine has killed at least 64,000 people. The Moderna trial data shows that over 13,000 lives may have been saved, but that is optimistic because the dominant variant has shifted. In short, the Moderna vaccine will kill at least 4.8 people from all-cause mortality for every life we might save from COVID. It simply makes no sense. Reason number 3, the vaccine fails on an absolute safety basis. The Moderna vaccine kills at least 643 people per million, as I just pointed out. That makes these vaccines nearly 1,000 times deadlier than the smallpox vaccine, which previously was the most deadly vaccine in human history and is considered too unsafe to use by experts. Reason number 4, you should not approve the vaccine until you see all the safety signals. Although the phase 3 trials claimed no safety concerns were identified, there are hundreds of very serious adverse events that are being ignored. For example, according to the VAERS US data, the average rate of pulmonary embolism reports is just 3 per year. With Moderna, we have 1,245 events, 415 times normal. How can that not be flagged as an adverse event? The only way that can happen is if the people who are in charge of monitoring the safety signals are either blind or corrupt. The public is not being informed of hundreds of safety signals like this. Some people believe that the reports in VAERS are unreliable. There's no evidence of this. In fact, the individual doctors report seeing adverse event rates that are 20,000 times higher than any other vaccine. These doctors are afraid to speak out due to threats and intimidation by state medical boards and others. And there were Facebook vaccine injury support groups with 250,000 people that were deleted by Facebook. Both of these anecdotes are impossible to explain if the COVID vaccines are truly safe and effective as claimed. Again, all of the supporting data is posted to my Substack at stevekirsch.substack.com. Thank you.
Thank you for your comment. Our next public comment speaker is Dr. David Wiseman.
Hello. Can you hear me now?
Yes, please go ahead.
All right, thank you. Sorry, beg your pardon. Yes, thank you. FDA have repeated the regulatory misdirection used for Comirnaty by BLA approving a non-available Spikevax and maintaining an EUA for a legally distinct Moderna product with, quote, certain differences that do not impact safety or effectiveness. This nonsense, somewhat repeated in a presentation later today, was rationalized at the August 30th ACIP by the suggestion that full approval of one quasi-vaccine would motivate 31% of vaccine hesitants to take any of the 3 vaccines. This product is obsolete. Its pre-Omicron efficacy is irrelevant to this discussion, and no Omicron data have been presented today. The Spikevax indication is prevention of COVID, but it fails to meet FDA's guidance VE target of 50% with a lower confidence boundary of 30%. Not shown in the grave presentation later today is a Danish Hansen et al. Study with an initial 37% Omicron VE waning to negative 39% by 3 months. Neither is the Canadian Buchan study, with VE starting around 0, dropping to minus 40%. The February the 3rd UK report shows Omicron VE waning to around 50% by 5 weeks and below 30% by 15 weeks before the 5-month authorized boost interval. None of these support the indication of COVID prevention within FDA guidance. Whatever VE can be mangled out of spikebacks with boosting with a risk of immune erosion would only have been relevant had 3 doses, not 2, been included in the BLA. With almost no benefit, we are left with risk. There has now been enough time to collect data, but the label that says there are insufficient data to inform risks in pregnancy, something similar for lactation as well. Yet CDC still recommends vaccination in pregnancy and lactation. The label and CDC statements conflict regarding immunocompromised, who may have a diminished immune response to spikebacks. The trial saw herpes zoster reports double, and the effects of spikebacks on cancer, mutagenicity, and male fertility have still not been evaluated. Our earlier written comments documented intense safety signals for death, MI, coagulopathy, and thrombotic events. For myocarditis, FDA and Pfizer have acknowledged underreporting by 4.8 times. A recent MMWR paper revealed theirs 6.5 times underreporting for hospitalization in children. Still, spikebacks is not regulated as gene therapy product, as Moderna said in a 2020 SEC filing. We still lack the full sequence of this nucleoside-modified mRNA. Moderna's founders previously wrote that their first application will likely not be a vaccine because the tolerance for side effects is very low in healthy individuals. If the use of booster doses was considered the last whack-a-mole, according to Dr. Long at the last ACIP meeting, using an obsolete product that ventures into negative VE territory before the authorized boosting interval must surely put us way beyond the last whack-a-mole. Thank you.
Thank you for your comment. Next, we have Ms. Elizabeth Dietz.
Good morning, Dr. Lee and committee members, and thanks for your tireless work in this pandemic. My name is Liz Dietz, and I'm speaking for myself as a citizen and as a grandmother. I strongly support the BLA for the Moderna vaccine and moving with all due speed to approve vaccines for under 5s. The effects of the pandemic are universal, but also hyperlocal, and the inequalities in vaccine access and other NPIs are noticeable. I live in San Mateo County, California. Because of the strong public health leadership in my county and state, we have been doing relatively well. 86% of county residents 5 years and older have been vaccinated. The Omicron testing trend is going in the right direction, dropping from 16% positive in January, beginning of January, to a 7% positive rate on January 31st. But we are failing to reach some of our most vulnerable population elements. The Pacific Islander population, the Black African American community, and the Hispanic population are all less than 63% fully vaccinated. The February 1 report from the Kaiser Family Foundation is, for me, hard to put a shine on. 8 in 10 parents of unvaccinated kids don't say that Omicron doesn't make a difference, and 1/4 of the parents say they will definitely not get their 12 to 17-year-olds vaccinated for COVID-19. Why the resistance? On February 3, Brandy Zarodny published anti-vaccination groups have enjoyed a pandemic windfall. She reported that the Big Trees Informed Consent Action Network reported $5.5 million in revenue in 2020, a 60% increase over 2019. Robert Kennedy's organization, Children's Health Defense, more than doubled its revenue in 2020. By contrast, two pro-public health groups, Voices for Vaccines, budget was $600,000, and Vaccinate Your Family noted that they had $1.6 million in revenue. Pro-public health groups are woefully losing the funding race, and so these bad ideas spread. I'd like to point your attention to the Urgency of Normal group that has developed a platform for parents to convince school boards to give up NPIs and throw it open. I have no solutions other than to push back against these false ideas. The right to health is a fundamental right, even for the smallest children. None of us is safe until all of us are safe. Thank you for this opportunity to share my concerns with you.
Thank you for your comment. Our last public speaker for the session is Evelyn Pinheiro.
Good morning. Can you hear me?
Yes, we can. Please go ahead.
As an informed member of the public, a teacher, a mother of small children, I am in complete support of the BLA for the Moderna vaccine. I also belong to a group of parents and physicians called Protecting the Future, and we specifically implore you to expedite the authorization of this vaccine for children under 5 once it's deemed safe and effective. This is the only segment of the population who does not have access to a vaccine. Pediatric hospitalizations surged during the Omicron wave, and a full half of them in New York were from the 0 to 5 age group. At a time when districts are repealing their masking mandates and going back to normal, which mine just did last night, we still have no normal. I have no protection for my preschooler in school now, and parents of children under 5 note the same thing to me. While myocarditis has been a side effect under discussion, physicians note that this doesn't seem to be an issue in prepubescent children. If the committee feels they must limit usage to certain age groups due to this risk, we ask you to humbly bypass the age de-escalation barriers that would prevent the vaccine from being used in the younger age groups. We do have the upcoming possibility of a Pfizer vaccine, but especially in the 2 to 4-year-old population, this will be the subject of much debate. We desperately need access to the Moderna vaccine for the under 5 age group. In addition, I also implore you to allow off-label use for our children, especially those on high risk. Once Moderna is deemed safe and effective in the under 5 age group, please do everything in your power to expedite its EUA, including bypassing age de-escalation barriers.
Thank you for your comment. Next, let me actually just pause for a moment and thank all of our public comment speakers. We appreciate the engagement in our open public meeting. We will now move on to the vaccine safety session. We will have 2 presentations from our CDC colleagues, followed by a summary and assessment from Dr. Kip Talbot, who chairs the COVID-19 Vaccine Safety Technical Work Group. We'll begin with Dr. Tom Shimabukuro, who will provide updates on myocarditis and pericarditis following Moderna COVID-19 vaccines. Dr. Shimabukuro, the floor is yours.
Thanks. Can I get a quick sound check? Can you hear me okay?
We can hear you. Thank you.
Thanks. Hi, good morning. And today I'll be giving an update on myocarditis and pericarditis following Moderna COVID-19 vaccination. Next slide. I'll discuss reporting rates of myocarditis following Moderna COVID-19 primary series vaccination in the Vaccine Adverse Event Reporting System, or VAERS, among persons ages 18 years and older. Describe care and outcomes of persons ages 18 years and older with myocarditis after Moderna primary series vaccination reported to VAERS. And then describe a vaccine safety data link, or VSD, subgroup analysis of confirmed myocarditis and pericarditis cases after primary series Moderna vaccination among persons ages 18 to 39 years. Next slide. So starting with VAERS. VAERS is the nation's early warning system for vaccine safety. It's a spontaneous reporting or passive surveillance system that's co-managed by CDC and FDA and has been in effect since 1990. Next slide. As a passive surveillance system, VAERS accepts reports from everyone, regardless of the plausibility of the vaccine causing the event or the clinical seriousness of the event. The key strengths for VAERS is that we can rapidly detect potential safety problems and can detect rare adverse events. Key limitations are those of spontaneous reporting or passive surveillance to include inconsistent quality and completeness of information, reporting biases, and generally we cannot determine cause and effect from VAERS data alone. Reports to VAERS do not necessarily mean that the vaccine caused the adverse event. Next slide. So I'll start with a table on reporting rates, and this is per million doses administered of myocarditis among males after Moderna COVID-19 vaccination in the days 0 to 7 after vaccination. Day 0 was the day of vaccination, and this is data through January 13th, 2022. So for the overall numbers, during that period, there have been 76.6 million total doses of Moderna COVID-19 vaccine administered to males. These are both doses, dose 1 and dose 2. And during that time, there have been 283 myocarditis case reports in the days 0 to 7 after vaccination that met the CDC case definition. These are reports where we follow up to get medical records or interview the provider, and we confirm that the case report met CDC case definition. On the table there, you see the table for males, and it's broken down by ages in the age groups and by dose 1 and dose 2. Those are, again, reporting rates, are rates per million doses administered. And the numbers highlighted in peach are those where the reporting rates exceed the background incidence, and we determine the background incidence based on literature, based on published data in the scientific literature. So after dose 1, in the age groups 18 to 24, 25 to 29, and 30 to 39, the reporting rate exceeded the background incidence, 5.8 per million, 2.9 per million, and 3.3 per million. And then after dose 2, the reporting rates exceeded background incidence in the 18 to 24-year-old age group, 25 to 29, 30 to 39, and 40 to 49. And you can see from this table, reporting rates are consistently higher after dose 2 versus dose 1. However, when you get to 50 and older, the reporting rates are not exceeding the background incidence, and there really is not much difference between dose 1 and dose 2, as you might expect. Next slide. So this is a similar slide, but looking at females. So reporting rates per million doses administered of myocarditis among females after Moderna vaccination in the days 0 to 7 after vaccination. Again, data through January 13th, 2022. For the total numbers, there's roughly 85.7 million total doses of Moderna administered to females. And during this analytic period, we had 76 myocarditis case reports in the days 0 to 7 that met CDC case definition. And the reporting rates exceeded background incidence after dose 2 in the age groups 18 to 24 and 25 to 29. So it would probably be easier if these were on both slides, or if the tables were on both slides. But what we basically see, if you could switch back to the previous slide, you see that the reporting rates exceeded background incidence in more age groups for males for dose 1 and dose 2. And just the overall reporting rates were higher. Could you go to the next slide, please? And that's evidence by the actual numbers and by the highlighting of these slides in teach where the reporting rates exceeded the background incidence. You see only after dose 2 in females and only in the 18 to 24 and 25 to 29-year-old age groups. Next slide. So in this slide, I describe the care and outcomes of myocarditis cases reported to VAERS after the Moderna primary series among persons ages 18 and older. Again, these are case reports in the 0 to 7 days after vaccination. So of the 359 case reports meeting case definition, most 337 were hospitalized, 335 were discharged. 230 or 69% were known to have recovered from symptoms at the time of the report. 2 had disposition under review. 22 were not hospitalized. They were seen in the emergency department, urgent care, outpatient clinics, or was not specified. Next slide. So in summary, 164 million total doses of Moderna COVID-19 vaccine were administered to persons ages 18 years and older as of January 13th, 2022. There were 359 total reports of myocarditis to VAERS in the 0 to 7 days following vaccination that met CDC case definition. Reporting rates of myocarditis exceed background rates for males in the ages 18 to 49 years, depending on dose, and in females in the ages 18 to 29 years after dose 2. Reporting rates of myocarditis were generally higher following dose 2 versus dose 1, especially in males. Most myocarditis patients were hospitalized and most were discharged home. Most discharged patients, 69%, had recovered from symptoms at the time of discharge. I do want to mention that VAERS is a surveillance system and is really not designed to assess the long-term outcomes, and we recognize that, and we have a special enhanced surveillance project that is following up. I'm doing a detailed follow-up on these case reports to further assess recovery status and long-term outcomes, and you'll hear about that in the next presentation. Next slide. So moving on to the Vaccine Safety Data Link. This is a collaborative project between CDC and 9 integrated healthcare organizations that you see here on the map. It's an electronic health record-based system, and it was established in 1990. Next slide. So we conduct rapid cycle analysis in the Vaccine Safety Data Link, and that's to monitor the safety of COVID-19 vaccines weekly using pre-specified outcomes of interest among the VSD member population, and to describe uptake of COVID-19 vaccines over time among eligible VSD members overall, and then strata by age, sex, and race and ethnicity. And monitoring began in December 2020 when the vaccines became available. Next slide. So these are the VSD COVID-19 vaccine rapid cycle analysis pre-specified surveillance outcomes and the settings in which we monitor them. Next slide. So the analytic strategy for the primary analysis, we look at the number of outcomes observed in the risk interval after vaccination compared to the number expected. The expected counts were derived from vaccinated concurrent comparators who were in a comparison interval after COVID-19 vaccination. On each day that an outcome occurred, vaccinees who were in their risk interval were compared with similar vaccinees who were concurrently in their comparison interval, and the comparisons were adjusted for age group, sex, race and ethnicity, VSD site, and calendar date. Next slide. So the myocarditis and pericarditis electronic case identification follows this pathway. Cases are initially identified using ICD codes, and you see the code list there on the right-hand side. And this is followed by chart review and adjudication of these cases by clinical subject matter experts using the CDC case definition. So this is a chart-confirmed analysis. Next slide. This is the VSD mRNA COVID-19 vaccine totals, the uptake in persons ages 18 to 39 years. The Moderna vaccines are in the blue lines with dark blue Moderna dose 1 and light blue Moderna dose 2. And through the analytic period, there were about 923,000 Moderna dose 1s and about 901,000 Moderna dose 2s. Next slide. So this table shows confirmed myocarditis and pericarditis cases identified in the 0 to 7 day risk interval among persons ages 18 to 39 years compared with outcome events in vaccinated comparators on the same calendar days from Moderna COVID-19 vaccination. These analyses are through January 15th, 2022. So on the left-hand side of this table, you see the Moderna COVID-19 vaccine doses. And then in the next column, you have events in the risk window. The risk interval is 0 to 7 days, both the raw counts and then the per million doses, then the events in the comparison interval, and then the adjusted rate ratios, p-values, and the excess cases in the risk interval per million doses. The excess cases are the excess cases in the 0 to 7 days compared to the cases in the comparison interval at 22 to 42 days. So looking at dose 1, this is the second row, you'll see that the risk is The adjusted rate ratio is 3.46 and is statistically significant, and that equates to an excess cases of 6.9 per million doses administered. Then looking at dose 2, we see an adjusted rate ratio of 18.75, which is highly statistically significant, confidence interval from about 6.7 up to 65, and 31.2 excess cases in the risk interval per million doses administered. So the columns, the bottom two columns in blue there are actually subsets of the dose 2, where we're looking at males and females separately. You can see the adjusted rate ratio in males is 16.96, with a confidence interval of 6 up to about 59, with an excess number of excess cases of 61.8 per million doses administered. And then for dose 2 females, we have a small number of events. The adjusted rate ratio is not estimable because we don't have any comparison events in the comparison interval. However, we can calculate a lower bound of the 95% confidence interval, and we have 6.2 excess cases in the risk interval per million doses administered. Next slide. So in summary, there are about 920,000 dose 1 and about 901 dose 2 Moderna COVID-19 vaccinations that have been administered in the VSD during the analytic period through January 15th. VSD analyses with vaccinated concurrent comparators indicate that Moderna COVID-19 vaccination is associated with an increased risk of myocarditis and pericarditis in persons ages 18 to 39 years. The increased risk was observed after both dose 1 and dose 2 in the 0 to 7 day risk interval, with risk greater following dose 2. The dose 2 adjusted rate ratio was 18.75 versus the dose 1 adjusted rate ratio of 3.46. The highest excess cases per million doses administered were observed after dose 2. There were 31.2 excess cases per million doses administered in both males and females combined, and 61.8 excess cases in the risk interval per million doses administered to males. Next slide. I'd like to acknowledge the contributions of the following groups to this presentation. Next slide. Next slide. That concludes my presentation, and I'll be happy to answer questions, or if you want to move to the next presentation, I'd be happy to answer at the end of the session.
Thank you, Dr. Shimabukuro, as always. Are there any questions that the committee members or ex officio or liaisons would like to ask? And you'll have multiple opportunities during this vaccine safety session. First, we'll move to Dr. Paling.
All right. Thank you, Dr. Shimabukuro, for a great presentation. The question I wanted to ask related to a public comment. And so I wanted to have you help us explain for everybody about the difference in the reported cases of myocarditis and those that met the CDC definition, and why that's so important. Thank you.
Sure. So the VAERS data are based on spontaneous reports. So anyone can submit a report, a patient, a parent, healthcare provider, caregiver. These reports come into CDC in different states of completeness. And one thing that we do when we get these reports that are suspicious for myocarditis, we follow up on them by reaching out to the reporter. Specifically, we try to contact the healthcare provider, the healthcare facility, to get medical records so we can basically review these medical records, fill in missing information or confirm information in the report, or correct information that may be erroneous in the report. We sometimes actually speak to the healthcare provider over the phone, and we gather enough information where we feel that we can be confident applying the CDC case definitions for myocarditis and pericarditis, which are published in the MMWR. And this adjudication is done by clinicians who are trained in doing this. and then basically we put these into categories where we can say these meet the case definition, the CDC case definition. Some we don't have information to evaluate, and some we determine do not meet the case definition because they aren't myocarditis, or they just the evidence, the information that's provided leads us to believe that this is not a true case of myocarditis. In our analyses, the reporting rate analyses and our evaluation of these reports is based on reports that have been reviewed, adjudicated to meet the CDC case definition.
Thank you. Dr. Lair?
Thank you for this presentation. You focused on the 0 to 7 day interval, but I wonder, did you also study day 8 to 21 for comparison? So if someone called in and had chest pain and elevated troponin on day 10 after the vaccine, what would happen to that report? Thank you.
So we do that analysis, and in the enhanced surveillance follow up on these, which you'll hear next, we do follow up on all cases that meet the CDC case definition for myocarditis. We know from reviewing VAERS data and from data in our vaccine safety data link, and also from data that's been generated from other international partners, that these cases do cluster in the day 2 to 3 to 4 after vaccination. In order to focus our analysis for this particular presentation, we decided to concentrate on cases that present or have symptom onset within the week of vaccination. We do have analyses that look at other intervals, mainly up to 21 days. But I think the data that we have right now, show a clear clustering in the several days after vaccination, and that's what we focused this presentation on.
Thank you. Dr. Brooks?
Yes, two quick questions. One is similar to what Dr. Lair just asked. So in the VSD data, you had the 0 to 7 days and then the 22 to 42. Was the rate in the 22 to 42 equal to what we expect to see in background, 0.2 to 2.2? And then the second question is, there were 335 hospitalizations and 359 cases in the VAERS data, and all went home were discharged with, and 2 are under review. So I'm curious whether those 2 under review, were there any deaths?
I don't know the answer to I think one of the questions you're asking is, what is the rate in the 22 to 42 days in the vaccine safety data link data? I don't have that information available to me. To get to the interval question, and I haven't presented this, but the VSD has in the past looked at different intervals of 0 to 7 and 0 to 21 days. And I think what we've noticed is when you look at the risks or the rates in these 2 intervals, most of it is concentrated in the 0 to 7 days. So I think we are pretty confident that these vaccine associated cases tend to cluster fairly closely after vaccination. And then with respect to your question of the cases and our follow up on these cases after primary series Moderna vaccination, there are reports of death where there was histopathologic or clinical evidence of myocarditis following vaccination, and we have reviewed those cases. But when we review those cases and do a thorough review and work with our partners out in the States, we don't have any cases where we've been able to definitively conclude that the vaccine was in the causal pathway for the death. And actually, if you can flip to I think it's the last extra slide. Can you go to the last extra slide, please? I'm sorry, the second to the last extra slide. This may give you some specifics on this, and this includes all deaths, not just Moderna deaths. It's all deaths death reports to VAERS among persons under 30 with myocarditis after primary series mRNA vaccination. So I just kind of want to walk you through this because I think this visual is probably going to best address your question and your concerns. So there were 13 cases with concern for myocarditis, 13 death reports with concern for myocarditis that we have identified through January. Of these, 3 did not have adequate information available to assess. You know, in some cases there was a death, but with clinical evidence of myocarditis, but there was not an autopsy or the conducted or additional tests, which really did not allow us to assess these cases. That left us with 10 with available information. Of those 10, 2 are ongoing. So we have 8 where we've completed the evaluation. Of those 8, 3 were not myocarditis. 5 were myocarditis. And of those 5, all 5 had potential infectious causes identified, so other potential etiologies identified, and that left us with no cases where there was no other cause identified. Does that help?
Very much. Thank you.
Thank you. Next, we'll move to Dr. Pablo Sanchez, and then we'll move to our next speaker.
Thank you, and thank you, Dr. Shimabukuro. Just a couple things. In your slide 16, when you talk about the 923,000, those are administered to age 18 to 39 years? Or is that the total?
Yeah, could you go up to the graph, the actual graph of the I'm sorry, slide 14. Could you go to slide 14, please? So yes, so these are the numbers that you were looking at in a figure. So these are COVID vaccine doses administered to persons 18 to 39 years. So this is the study population that we're looking at.
Okay, great. Thank you. And then another question. I wanted to go back to the age and, looking at it beyond 7 days, only because in the study, in the randomized study, the cases of pericarditis, there was no myocarditis, occurred in older, more removed from the vaccine administration. So, it'd be important also to know that those may not have been related to the vaccine administration, but if they occurred late, I think they were like 69 days, 43 days after those 2. And so, I think it's important to also look at it beyond to at least see if there was no relationship. But and then my last comment is just that there was also an increase in males in 40 to 49 years, if I remember. And so that's not part of your analysis currently.
Yes. Could you go to slide 5?
Yeah. So 40 to 49 after dose 2, there was a slight increase, not a sign.
Yes. So you're correct. In the VAERS analysis, we did notice an increased reporting rate above what we would expect based on baseline in males in the 40 to 49-year-old age group after dose 2. That age group, we are monitoring for myocarditis in that age group in the vaccine safety data link. We monitor in all ages, in fact. When we did our analysis, it was restricted to that 18 to 39-year-old age group, at least for Moderna, and that's largely a numbers issue. The more you extend, the less numbers you have relative to doses administered. So that was largely based on the number of cases.
Thank you.
Thank you. We will move on to Dr. Ian Kreselek to update us on myocarditis outcomes, known as the MOVING study. So Dr. Kreselek?
Thank you. So I'll be updating you on myocarditis outcomes following mRNA COVID-19 vaccination. Next slide, please. This is just a disclaimer. The conclusions in this report don't necessarily represent the official position of the CDC, and any mention of a product or name does not constitute endorsement. Next slide, please. So looking at the occurrence of myocarditis following mRNA COVID-19 vaccination, we observe evidence from safety monitoring systems in multiple countries that supports the finding of an increased but small risk of myocarditis following mRNA COVID-19 vaccination. And this risk of vaccine-associated myocarditis appears highest in adolescents and young adults, increased risk in males compared to females, and an increased risk following dose 2 compared to dose 1. Typically, onset is within a few days of vaccination, with most presenting within a week following vaccination. The severity of cases varies. Most who presented to medical care have responded well to medications and rest, and assessment of myocarditis health effects after COVID-19 vaccination are in progress. Next slide, please. So CDC initiated enhanced surveillance for myocarditis outcomes after mRNA COVID-19 vaccination in Vaccine Adverse Event Reporting System, or VAERS, case reports. The purpose of this enhanced surveillance was to assess functional status and clinical outcomes among individuals reported to have developed myocarditis after receiving mRNA COVID-19 vaccination. And this enhanced surveillance involved a 2-component survey conducted at least 90 days after the onset of myocarditis symptoms. The first part was a patient survey focused on 12 to 29 years of age to ascertain functional status, clinical symptoms, quality of life measures, and the need for medication or other medical treatment. The second part was a healthcare provider survey, which, for example, involved cardiologists. And the objective was to gather data on cardiac health and functional status. The timeline for the data collection was approximately between August of last year and January 2022. Next slide, please. So first, I'll present some preliminary data from surveys of patients at least 90 days post-myocarditis diagnosis. Next slide, please. So our outreach was focusing on myocarditis patients 12 to 29 years of age. As of November 2021, VAERS had received approximately 989 reports of myocarditis or myopericarditis after COVID-19 vaccination that met the CDC case definition. Of these, approximately 850 patients aged 12 to 29 years had reached 90 days post-myocarditis diagnosis. Of the approximately 850 patients 90 days post-diagnosis, 81% had a phone number listed in which we could contact them. Of those 648 who were called, 56% completed the survey, 42% were unreachable, and 3% declined to participate. For the 360 patients interviewed, the time from myocarditis onset to interview was 143 days, with an interquartile range of 131 to 162 days. Next slide, please. So if we look at some of the demographic characteristics of these myocarditis patients, we see most patients diagnosed with myocarditis were young males. If we look at the graph below, we see age group and sex on the x-axis, and we see male patients in the dark blue and female patients in the light green. Median patient age was 18 years, with an interquartile range of 15 to 22 years. Of the 360 patients 90 days post-myocarditis diagnosis, 86% or 308 were males. Next slide, please. So here we have the race and ethnicity of myocarditis patients. Most patients were white, non-Hispanic. Hispanic of any race made up 20% of patients, Asian non-Hispanic 5%, Black non-Hispanic and multiracial non-Hispanic 4% each, other non-Hispanic 3%, and American Indian or Alaskan Native non-Hispanic less than 1%. Next slide, please. So Prior to the patient's myocarditis diagnosis, most patients received 2 doses of the COVID-19 vaccine. 87% reported receiving 2 doses. Of those who received 2 doses, 98% reported receiving both doses before they were diagnosed with myocarditis, and 9% had evidence of COVID-19 with a positive COVID-19 test before their myocarditis diagnosis. Next slide, please. So if we look at some of the self-reported previous medical history among these patients with myocarditis after mRNA COVID-19 vaccination, see that 17% reported having any condition, 3% reported having an arrhythmia, 2% each had a congenital heart disease or a history of myocarditis, and then less than 1% each had Kawasaki disease or had a history of previous heart failure. 9% had a history of asthma, 2% had an autoimmune disorder, 1% each had genetic or chromosomal condition or were immunosuppressed, and then less than 1% each had a history of leukemia or had type 1 diabetes. Next slide, please. And most patients with myocarditis after receiving COVID-19 vaccination reported being hospitalized at the time of their diagnosis. So 92% were hospitalized, 4% were readmitted following myocarditis. Of these that were readmitted, 62% were readmitted because of a concern with the heart, and 20% were prescribed medication for their heart as of their last appointment with their provider. Next slide, please. So if we look at absenteeism related to missed school or work within the 2 weeks prior to the date of the interview reported among patients, see that 46 or 8% reported missing school. Of these, 37% believed it was due to their myocarditis, and 5% missed work. Of these, 37% believed it was due to their myocarditis. Next slide, please. So here we have the self-reported symptoms within 2 weeks prior to the date of the interview among myocarditis patients. This is looking at 4 main symptom types. So from top to bottom, we have chest pain, shortness of breath, palpitations, and fatigue. We have those experiencing the symptoms in yellow and those not in dark purple. We see about a third were experiencing chest pain, and about a quarter each were experiencing shortness of breath, palpitations, and fatigue. If we look at any symptom reported across all patients, we see about half, or 49%, reported experiencing at least one of these symptoms in the prior 2 weeks to the date of the interview. Next slide, please. So here we have the EuroQol 5-dimension, 5-level severity measurement of health status among patients who develop myocarditis after vaccination. This is an assessment of the patient's quality of life. We have on the x-axis below in this graphic, we have the quality of life measure or dimensions that we're looking at. We have the ability to do self-care, the ability to walk or mobility. We have the ability to perform usual activities, whether they're experiencing any pain or discomfort, and whether they're experiencing any anxiousness or depression. The 5-level of severity measurements can range from experiencing no problems to experiencing extreme problems. In this case, we've categorized those into experiencing any problems, shown in light green, and experiencing no problems, shown in the darker colored bars. We can see that most patients reported experiencing no problems with self-care, mobility, or usual activities. Most did not experience any pain or discomfort. However, when we look at anxiousness or depression, almost half were experiencing anxiousness or depression. Next slide, please. So next I'll report on some of the preliminary data from completed cardiologist or other healthcare provider surveys. Next slide, please. So our outreach to cardiologists or other healthcare providers involved interviews. So of the 360 patients that were interviewed, 346 listed contact information for a cardiologist or other healthcare provider. Of those 346 that we were provided contact with, 229 completed a survey. An additional 151 providers completed surveys they had submitted for multiple patients in VAERS or we were provided contact information via the VAERS report. We were unable to reach 268 providers. In total, 380 providers completed the survey with a median of 191 days, with an interquartile range of 170 to 216 days from patient myocarditis onset to the date of the provider survey. Next slide, please. So we found that the proportion of myocarditis patients cleared for physical activity by their cardiologist or healthcare provider has increased. So at the time of myocarditis diagnosis, 83% of patients had restrictions on their physical activity, while at the time of the provider survey, at least 90 days post-diagnosis, only 39% had restrictions on physical activity. Next slide, please. So based on the cardiologist or other healthcare provider assessment, most patients appeared to have fully or probably fully recovered from their myocarditis. If we look at the graphic below, we have the 4 categories of recovery, either the same cardiac status at the initial myocarditis diagnosis, the patient has improved but not fully recovered, the patient has probably fully recovered, but the provider is awaiting some additional information, and the patient has fully recovered. So in total, 81% of cardiologists or healthcare providers indicated the patient was fully or probably recovered, with more than 90% showing some improvement. Next slide, please. So here we have the proportion of myocarditis patients deemed to be fully or probably fully recovered by their healthcare provider as a function of time. So we have the cumulative proportion of patients recovered. On the x-axis, we have time from myocarditis onset to most recent provider appointment shown in weeks. So at about week 38, we see that about 80% of patients were fully or probably fully recovered. Next slide, please. So here we're showing results of the most recent cardiac function test or biomarker test, looking at 6 specific tests. So we have troponin, cardiac MRI, echocardiogram, electrocardiogram, exercise stress test, and ambulatory rhythm monitoring. We have a normal or baseline test results are shown in dark blue, and abnormal or elevated are shown in light blue. Overall, most of the recent cardiac function tests were normal, with the exception of cardiac MRIs, which most were abnormal, as that's the most recent cardiac function test. Next slide, please. So here we have the abnormal findings from those most recent cardiac function tests. On the x-axis below, we have cardiac MRI, electrocardiogram, exercise stress test, and ambulatory rhythm monitoring. Results for all patients are shown in dark blue, and in light blue, we have patients fully or probably fully recovered. So for cardiac MRI, we see the most common abnormal finding in cardiac MRI was late gadolinium enhancement. Electrocardiogram, the most common abnormal finding was a T-wave abnormality. Exercise stress test, there was some other cardiac concern identified, and during ambulatory rhythm monitoring, the most common abnormality found was an arrhythmia. Next slide, please. So here we have overlap of abnormal findings among the most recent cardiac function tests. So, for example, looking at the first column, we have MRI, and then we have troponin at the top. We see that 51% of abnormal MRI findings also had an elevated troponin. 26% of abnormal MRIs also had an abnormal EKG. 3% of abnormal MRIs also had an abnormal ambulatory rhythm monitoring finding, and then 1% of abnormal MRIs also had an abnormal exercise stress test finding. Looking at echocardiogram across the bottom row, we see that a low percentage of abnormal findings for the most part in the overlap of abnormal echocardiogram findings and abnormal findings among these other tests. Next slide, please. So here we have a comparison of cardiac function tests at the time of diagnosis and at the time of follow-up. So there are two different time periods here: at the time of diagnosis on the left-hand side and at the time of follow-up on the right-hand side. We're looking at three tests here. We have cardiac MRI, echocardiogram, and troponin with three possible outcomes. And we have a normal test, abnormal test, or the result was not performed, or the test was not performed, or the result was not available. So if we go to the next slide, please, we can focus on cardiac MRI. So again, we have at the time of initial diagnosis on the left-hand side, and at the time of follow-up on the right-hand side. We see for the most part that many patients did not have an initial cardiac MRI performed, and we see those with an initial cardiac MRI that was abnormal also did not have a follow-up cardiac MRI. 79 patients had a follow-up cardiac MRI that was abnormal. Next slide, please. Here we're focusing on echocardiogram. Again, time of initial diagnosis on the left-hand side and time of follow-up on the right-hand side. Most patients had an initial echocardiogram that was normal and a follow-up echocardiogram that's normal. There were 17 patients that had a follow-up echocardiogram that was abnormal. Next slide, please. Here we're looking at troponin. We see that, again, most patients that had an initial troponin that was elevated didn't receive a follow-up test, or the test was not available. And on follow-up, 20 patients had an elevated troponin level. Next slide, please. So here we're looking at the cardiac assessment and symptoms among patients deemed to be recovered and not recovered from their myocarditis. So we have two different groups. At the top matrix there, we have patients deemed not recovered, and we have patients deemed fully or probably fully recovered at the bottom. This is looking at a subset of some symptoms and tests and healthcare provider assessment. So we're looking at shortness of breath, chest pain, daily medication, physical activity, troponin, echocardiogram, EKG, and cardiac MRI. Each row represents one of those tests or symptoms. Each column represents an individual patient. Normal or baseline function or absence of symptoms is shown in blue. Abnormal function or presence of symptoms is shown in red, and unknown or the test result not available shown in white. So if we go to the next slide, please. You can see among those patients deemed to be fully or probably fully recovered, there are a few patients that have a complete normal baseline function or absence of symptoms across this subset of tests and clinical assessments. Some also had normal baseline function, but were missing cardiac MRI results. Next slide, please. And even among patients deemed not recovered, we see that some of them had normal or baseline function or absence of symptoms across all this subset of tests and clinical assessments, which suggests that there's some heterogeneity in the way patients are deemed recovered, and there's likely a lot of healthcare provider judgment in the assessment of these patients. Next slide, please. So in summary, at least 90 days after myocarditis diagnosis, most patients reported no impact on their quality of life, and most did not report missing school or work. A few were readmitted to the hospital. Most healthcare providers indicated the patient probably or fully recovered. However, there did not appear to be a single test that was indicative of recovery. And to our knowledge, there were no vaccine-associated myocarditis deaths in this group of patients that we interviewed. Currently, there are ongoing efforts to continue patient follow-up and contact myocarditis patients who are not yet recovered at the time of the survey. There are additional surveys are being modified for children aged 5 to 11 and follow-up to start in February 2022. Next slide, please. I'd just like to acknowledge all the individuals and teams that made this analysis possible. Next slide, please. Thank you.
Thank you very much. I'd like to open up this presentation for clarifying questions, and then would want to remind our committee members that we have Dr. Talbot, who will also provide a summary and assessment. Dr. Paling.
Yes, Dr. Kresolek, thank you very much for this presentation. I really appreciate the additional data and follow-up from the patients and the providers to understand what's going on. I wanted to ask a clarifying question, and you focused in the VAERS database on 12 to 29 years of age. Knowing that you went down to 12 years of age, I'm assuming this data is for Pfizer or Moderna vaccine, and that's why some of these numbers look different than what Dr. Shimabukuro presented earlier. Is that correct? Thank you.
That is correct. It's both the Pfizer and Moderna vaccine.
Thank you. Ms. Bata.
Thank you. And thank you, Dr. Kresolek. I had the same question about this data being any mRNA vaccine, but also in your survey, was there any assessment of social or behavioral impact and whether those types of impact from the myocarditis have been resolving? When I'm looking on slide 16, slide 19, it looks like the recovery, 50% recovery happened shortly after 16 weeks. And so that's a long time for a person to maybe be with limited activity or may not be able to work or anything like that. So I just want to make sure that we're not just looking at the physiology, but the whole impact of a person who ended up with myocarditis after getting vaccinated. Thank you.
Certainly, and we attempted to get at that by assessing the quality of life measures. So we did administer the Euroqual 5-dimension, 5-level severity measurement of health status, which did look at some measures, including anxiousness or depression, as well as being able to perform usual activities. And while most appeared to be able to perform usual activities, we did find that about half were experiencing some level of anxiousness or depression, which could have been extreme.
Thank you.
So there was probably some impact because of that.
Thank you.
Thank you. And actually, Dr. Cotton, if you'll indulge me for a moment, I just wanted to follow up on this particular comment, which is, well, first, I wanted to thank the teams that have been involved in this particular study. We recognize that the study was going above and beyond in order to respond to the pandemic and ensure that the committee and the public had the information it needed about the long-term follow-up of these cases. Second, I just wanted to highlight that because we're doing long-term follow-up on cases only in order to ensure we have these long-term outcomes, we also don't have any controls in this long-term follow-up study. So the medical information from the long-term cardiology follow-up, I think, continues to reflect disease that is mild and consistent with what we've seen previously. But what I found remarkable is, and telling, is that some of the patient and family-centered measures, such as the Euroqual measures that you described, as well as some of the return to activity measures, that we are seeing there is a substantial impact on individuals, but we have to acknowledge that these data likely reflect the experience that many of us are having living through this pandemic, whether or not we're infected or vaccinated. So I'm actually hopeful that other ongoing studies supported by the CDC, by NIH, and by the FDA will continue to shed light on the impact of this pandemic on our children and young adults. With that, I will actually turn it over to Dr. Cotton.
Thank you, Dr. Lee. I wanted to emphasize your point, which is this data, although clearly very robust and very interesting and helpful for us to look at, it's really hard to fully understand what this means in isolation. And most of the time in the medical world, we don't look at data without a control population or other populations to compare to. So I would encourage, obviously, regular people aren't getting cardiac MRIs and all of that, of course. But I would consider doing work where you could look at people who had myocarditis from true infection, which has been devastating and has a much bigger impact, I think, than these vaccine-related myocarditis. And then I would also, for the epidemiology, it would be helpful to have controlled populations. And I would just encourage further speakers on this topic or people doing work to make sure that they have good comparison populations. I think that there's a little bit of danger in focusing on vaccine and myocarditis when the elephant in the room is really true disease and true infection from COVID-19 and the potentially devastating, even life-threatening myocarditis we see in that setting. Thank you.
Thank you, Dr. Cotton. And we'll move on to Dr. Brooks.
Yes, very briefly. Can you go to that almost next to last slide where you had the fully recovered versus not fully recovered, the blue and the red? And this kind of goes along, thank you, with exactly what the last two speakers said. If you look at the top four, shortness of breath, chest pain, daily medication, and physical activity, those are the ones that a patient would feel. The bottom four are a doctor finding. And you'll note that on the fully recovered, once you get toward the end, the top four are all clear, generally speaking. Even before, you noted all of them, but the troponin was elevated, some. But these patients on the quality of life relative to physical findings, chest pain, shortness of breath, and that physical activity, they recovered. So I think that's reassuring. And just one other thing in general for the public, I just think it's so important that we are doing this dissection of the myocarditis. I think that your data, along with all the other data we've seen, gives you a full picture. We're going to hear one more, at least one more. So I just want to point that out and then say thank you for your presentation.
Thank you, Dr. Brooks. And thank you, Dr. Koselleck. I think we will move on to Dr. Kip Talbot to provide a summary assessment of the vaccine safety technical work group's thoughts. So Dr. Talbot.
Thank you. All right, so this is the COVID-19 Vaccine Safety Technical Work Group, otherwise known as VAST, assessment of the data that was just presented and some other that has been reviewed. Next slide. So the objectives of VAST are to review, evaluate, and interpret post-authorization approval COVID-19 vaccination safety data. It serves as a central hub for technical subject matter expertise from federal agencies conducting post-authorization and approval safety monitoring. There's advice on analysis, interpretation, and presentation of vaccine safety data, and provide updates to the ACIP COVID-19 vaccines work group and the entire ACIP on COVID-19 vaccine safety. Next slide. VAST continues to review vaccination data, and this is done with the U.S. safety monitoring systems, including the Vaccine Adverse Events Reporting System, VAERS, which is done with collaboration of the FDA and CDC, the Vaccine Safety Data Link, the FDA BEST system, the Department of Veterans Affairs, Indian Health Service, and the Department of Defense. We continue to work with international partners, including the Public Health Agency of Canada and the Global Advisory Committee on Vaccine Safety. Special evaluations, including myocarditis case follow-up studies, as was just seen, have also been reviewed. Next slide. So from December 21st to today, VAERS has had 45 independent meetings to review vaccine safety data. There have been 12 joint meetings with ACIP COVID-19 vaccines work group, and there have been 15 ACIP meeting presentations or reports with VAERS assessments. Next slide. VAERS review of the Moderna COVID-19 vaccine post-authorization data includes CDC safety monitoring systems, as mentioned previously, including VAERS, VSAFE, and VSD, other U.S. monitoring systems, and international partners. Next slide. Previously, we mentioned anaphylaxis following messenger RNA COVID-19 vaccination. Anaphylaxis following messenger RNA COVID-19 vaccines was identified in December of 2020. Safety data and VAERS assessments were presented in January and March 2021. CDC and FDA recommended risk mitigation strategies, including screening for risk prior to vaccination, monitoring for symptoms post-vaccination, early recognition and management of anaphylaxis on site, provider and patient education by CDC and partners. Anaphylaxis following vaccination was reviewed again in August 2021 for the Pfizer BLA. There have been no substantial change in benefit-risk balance with risk mitigation strategies. Next slide. So myocarditis. Myocarditis following messenger RNA COVID-19 vaccination was identified in May 2021. CDC issued clinical guidance for myocarditis, pericarditis following messenger RNA vaccines in May. Data was presented to the Vaccines and Related Biologics Products Advisory Committee, otherwise known as VRBPAC, on June 10th. Data and VAERS assessment presented at ACIP meetings on June 23rd, and an MMWR was published. EUA fact sheets were revised with warning added June 25th. FDA approval of the Pfizer-BioNTech COVID-19 vaccine on August 23rd included information on myocarditis, pericarditis in the package insert. The FDA approval of Moderna COVID-19 vaccine January 31st also includes information on myocarditis, pericarditis in the package insert. Next slide. This is data from VAERS, which I will remind you is a collaboration with the CDC and FDA. These are reporting rates per 1 million doses administered of myocarditis in the window of 0 to 7 days after Moderna vaccination. And you'll notice the highlighted areas in green show that reporting rates exceed background incidence in males after dose 1 for males 18 to 39, and especially after dose 2 in males 18 to 49 years of age. In females, we see reporting rates exceeding background incidence after dose 2 in those 18 to 29 years of age. Next slide. You've seen this earlier this morning, and it's just a reminder that the risk interval is from 0 to 7 days, and mostly among 18 to 39-year-olds, and especially males following the second dose. Next slide. So myocarditis outcomes following messenger RNA COVID vaccination. So in VAERS, for all messenger RNA vaccines, we see 359 reports meeting case definition within the window in those adults over 18 years of age. 94% were hospitalized, and almost 70% have recovered from symptoms at time of the VAERS report. Follow-up surveys of myocarditis cases in VAERS, 360 patients interviewed with greater than 90 days of follow-up, 92% hospitalized, and 380 providers contacted. 81% indicated patient fully or probably fully recovered. From the Vaccine Safety Data Link, or VSD, comes information for Moderna vaccination alone. 38 chart confirmed cases among individuals 18 to 39 years of age. 79% were hospitalized, 75% for 2 days or less, and 100% have been discharged to home. Next slide. So the VAST assessment is as follows. Data available to date show association of myocarditis with Moderna messenger RNA COVID-19 vaccination in adolescents and young adults. Risk is low overall, but highest in adolescent and young adult males, especially following dose 2. Data continue to show that most cases of post-COVID-19 vaccination myocarditis appear clinically mild. More data are being accumulated and analyzed to further define myocarditis clinical course and risk. And at the present time, data do not suggest new safety concerns regarding Moderna vaccination among persons 18 years or older, beyond those that were previously identified and discussed. Next slide. Our work is not finished, and we continue to work. We continue to review data on myocarditis from national safety monitoring systems and manufacturer post-marketing requirements. Continue to review real-time monitoring of vaccine safety as vaccination efforts expand to younger age groups, booster doses, and new vaccines. We continue to collaborate across U.S. federal agencies, and we continue to collaborate with global vaccine safety colleagues on key issues that impact benefit risk. And we continue to provide updates to the ACIP COVID-19 vaccines work group and ACIP at future meetings. Next slide. I really have a shout out for all of these people. 45 meetings is a lot of meetings, and everyone shows up every time ready to work. And I especially appreciate my co-chair, Dr. Hopkins, who's the representative from NVAC, and our CDC co-leads, Lori Markowitz and Melinda Wharton. Thank you so much.
Thank you, Dr. Talbot. I'm going to pause and ask if there's any questions folks have for Dr. Talbot, Shimabukuro, or Koselik. Don't see any hands raised. We'll open it up to our liaison members. Okay, Dr. Daly.
Well, I just, Dr. Talbot, as you went through your presentation, I was just struck by how you balanced what we've learned so far with the idea that we still continue to have work to do. And I just kind of want to reiterate that. And that work's going to extend across new indications, but it'll also extend across learning more about the outcomes for these individuals with vaccination-associated myocarditis. So I just appreciate you putting it in that longer term big picture context. So thank you.
Thank you, Dr. Daly. Okay, I don't see any additional hands raised. So I think with that, we will plan to close this session. And I want to thank all of our presenters for their excellent presentations. We will now recess, actually not as long as we had hoped, but we will plan to reconvene at 1 p.m. Eastern Time, which I believe is 10 a.m. Pacific Time. Thanks, everyone, and we'll talk soon.